lost in the press lump examination. We have got with us Professor Manoharan Sir, Executive and Senior Professor from Manakula Vinayagar Medical College, Puducherry. Sir, welcome you, sir. We got Keshav Prasad, Professor of Surgery, KVG Medical College, Sulia. My good friend, quite close to me, a good surgeon, very academician. Keshav, I welcome you very much. Keshav, Tala, we have got Dr. Tala Ahmed. He was faculty in our college earlier. Now he is in the Manchester, UK, working there as a consultant over there. Tala, welcome you for this. He has been in my group since a long time. He was our faculty, quite close to me. He's a very good surgeon, very academician. Tala, welcome you. And I welcome Anup sir from Principal and Professor of Surgery, Agartala Government Medical College, Tripura. He will join soon. I welcome him when he joins actually. And I welcome Dr. Devish, staff faculty in my unit. I also welcome Dr. Saha. He is going to join faculty. I welcome Bipasha Deb from Agartala Medical College and Sourav Chakraborty, final MBBS, final professional students who is presenting the case. So, Sir, Manoharan Sir, we'll go straight and we'll discuss about the start the presentation, I think.
Yes, sir, please.
Sir will join
yes, sir.
in another 5-10 minutes. So, we'll start discussing. I think Bipasha, they will present the history. Over to Bipasha.
Yes. So, first of all, thanks to Dr. SRB Sir for giving us the great opportunity to learn with such great teachers. And my very special good evening to all my respected teachers present here. So, me and Sourav, today we are going to present a breast lump case.
Bipasha, 1 minute. Bipasha, 1 minute, sir. Anup sir has joined, I think. Sir, good morning. Good evening, sir. Anup sir, welcome you for the discussion. You have just started, sir. Anup sir. Start presenting, Bipasha. Next slide.
My patient, 64 years old female, hailing from Bilonia, South Tripura, homemaker by occupation, Hindu by religion, educated up to class 10. She admitted on 17th of November and we examined her on 18th of November 2025 around 9:30 a.m. So she came with the complaint of swelling in her right breast for last 9 months and swelling in her right axilla for last 3 months.
1 minute, Bipasha, 1 minute. Sir, good evening, sir. Welcome you, sir.
Good evening.
Sir, we got Manoharan Sir, Senior Professor from Puducherry. We have got Keshav Prasad, Professor from Sulia, and we other faculties. Anup Sir is from Agartala Government Medical College, the Principal and Professor of Surgery. So I met him recently, few weeks back. I had a very good hospitalization from him, and I saw went around and had a good discussion with all of them and attended state conference there. Sir, I warmly welcome you for the discussion. I really appreciate your you being with us, sir.
Okay, good evening to all. Good evening. Good evening, sir. Good evening.
Good evening. Thank you, sir. Sir, I will ask Bipasha to continue the presentation, sir.
Please proceed, ma.
Continue, Bipasha.
Yes, proceed.
Okay, sir. So her chief complaints were swelling in her right breast for last 9 months and swelling in her right axilla for last 3 months. Then history of present illness. So she was apparently alright 9 months back. Then my patient noticed a lump in her right breast which was insidious in onset since 9 months, which gradually increased in size from 2 cm to 5 cm and a single largest diameter. According to her, the initial size was 1 finger breadth, most likely 2 cm, and now the size increased to 5 centimeter, which she told like 2.5 finger breadth. Along with the lump in her right breast, she noticed another lump in her right axilla since last 3 months, which also increased in size to 3 centimeter. And there is no history, there is no pain associated with the lump, no aggravating or relieving factor associated with it, no history of any discharge or ulceration, no history of fever, back pain, breathing difficulty or headache. She has also lost weight and her appetite is poor. So her past history showing no history of any such swelling in her past, no history of use of any OCP pills or hormone replacement therapy known by her, no history of any chronic disease like hypertension, diabetes, hyper or hypothyroidism, TB in her past. She had undergone hysterectomy for uterine prolapse 12 years back. She has no history of any drug or medication allergies. Then, yes, she has significant family history. There are 6 persons in her family. No history of colon, ovarian, breast, prostate, tumor in her family, but there is a history of first degree family member, that is her younger sister, developed breast lump 10 years back at the age of 40 years, and she refused to follow up for initial visits to doctor. Then she developed a discharge from the nipple on left breast. She is undergoing now homeopathic treatment since then. Her mother had no history of such swelling in her breast. So this pedigree showing that her youngest sister, there are 6 siblings, and her youngest sister had similar kind of history. Next, personal history. So she attained menarche at 15 years of age and menopause 47 years of age. Her first pregnancy of 19 years. She has a total 9 pregnancies, 3 spontaneous abortions, mode of delivery vaginal delivery. Last childbirth at the age of 25. She has no history of OCP taking or no history of any known hormone replacement therapy taken. She takes mixed diet. Her bowel and bladder habits are normal. She gets adequate. She chews pan, tobacco, betel nut for last 45 years, but no history of smoking or alcohol. Her allergication, she has no history of any allergy to drugs, dust or the medication. Treatment history, she has not taken any treatment yet for the present condition. So my summary of the history is 64-year-old postmenopausal lady presented with swelling in her right breast for the last 9 months. The swelling was about 2 centimeter when she first developed 9 months back. The swelling gradually increased in size over time and attained the present size. Patient also complained of swelling in her right axilla since last 3 months. No swelling in the opposite breast or axilla. Her appetite is poor. Bowel and bladder habits are normal. She has no chest pain, back pain, cough, hemoptysis or breathlessness. Now, she underwent hysterectomy for uterine prolapse 12 years back. Her younger sister, here is a significant history of younger sister diagnosed with breast cancer 10 years back at the age of 40 years.
So Diksha, we'll go to first slide, go back. Okay, next. Next slide. So anything to comment, sir? This one. Manoharan, sir.
What is the significance of 64 years now? Bipasha?
Yes, sir. Sir, with increase of age, there is increasing risk of getting breast cancer.
Any other point?
Any other thing to you want to?
Lady with 64 years breast lump.
Yes, sir, postmenopausal
Very
lady.
good, very good, very good. Oh, post-menopause. That is one thing we remember. Yes.
Post-menopause management will differ. Outcome
Yes.
also may differ. No, that's why that
Yes.
is important. Like sir rightly highlighted.
Next.
Anup sir, anything to just add on to sir? Anything to please?
No, nothing.
Okay, sir.
On
Next,
this first slide, nothing to ask.
okay. Next slide. Sir, anything, sir? This slide, Keshav or anybody to add on to this one? Just to see mentioned in orderly fashion.
Yes, sir. Correct.
The link should come. Whatever.
Yes, sir.
That should come. So,
Yes.
sir.
Next slide.
Yes,
In this slide, I think what place should be shown here?
yes, sir.
In the slide, the language wise, I want to outpost base to fish. Now, okay.
Okay, sir. Sir, your voice is not clear, sir. Yes, sir. Anything to this slide, sir, Manoharan sir, Anup sir, Keshav?
Okay, I'm coming up to one point because I think this phone may be some problem. I think I am going to another phone. Okay.
Yes, sir. Please, sir. Yes, sir. Please, sir. Sir, Manoharan sir?
Yes, sir. Bipasha, but the picture is not straightforward picture. The patient is tilted. Why you need a picture of a straight picture? Can you tell me?
So we had a straight picture also, but I think.
Now, what is the importance? Why I am asking for the straight picture?
Yes, sir. We have to compare the size of the breast and
Yes.
then also the position of the nipple
Level of the
and level of the nipple.
Bible should be there.
Also,
affected side there is retraction. Can you see?
yes.
We
Yes.
draw a line, the right breast nipple appears to be little higher. So
Yes,
if you
sir,
can
yes.
put a picture by inspection, that point that is very clear cut also. So otherwise, alright, okay. Okay.
Okay. Why you want to ask pain, Bipasha?
So, painless swelling shows in neoplastic genes, but with pain, it may be due to mastitis also.
Okay. And can breast, carcinoma breast have pain?
Yes, sir. Yes, sir. But it happens in later stages when necrosis occurs.
Necrosis, hemorrhage, infiltration.
Necrosis occurs. Yes,
Not only
sir.
that, when the swelling grows in size in later stages, as you said, size will increase.
Yes,
So
sir.
it will stretch the skin. So stretching of the skin and it is going to break the skin. That is ulceration. Before the ulceration and fungation, and if it is infected, you will get pain. That is also benign conditions. Late stages, as you said, due to infiltration of the nerves, she may have pain. Okay, these are the conditions where you will learn.
Can carcinoma breast itself present as a pain, initially mastalgia? Usually painless.
Yes, sir. Usually
What is the
painless.
percentage of carcinoma breast patient presenting as a pain in the breast, mastalgia?
Sir, sometimes it can present with it if it is
To begin with,
greater. Yes, it is.
usually it is a painless. Around 5% of individual can present as a mastalgia. Without much obvious lump.
Lump.
So, mastalgia usually
Not the DDs of a persistent mastalgia with no obvious cause is always suspect carcinoma.
mainly mastalgia which is not related to the changes in the menstruation. Mastalgia in post-menopausal age. Even there is no lump, you have to suspect carcinoma. Okay. So, why back pain? You are specifically asked for the back pain.
Sir, for metastasis to bone,
Which is the commonest site of metastasis?
sir, lumbar vertebrae.
Huh?
Lumbar vertebrae.
Yes.
That is right. So, why you lost weight? Why you asked why specifically she lost weight? What is the significance of that?
Sir, it also normally breast carcinoma doesn't show loss of weight or loss of appetite initially, but in metastatic case, there may be loss of weight and appetite.
So what you are trying to say is cachexia. Malignant cases.
Yes.
The metastatic type with philosophy.
But as you said rightly, breast carcinoma very rarely produces that kind of.
Unless that's the regional threat, they will have metastasis. That is right. Keshav, anything to add? Tala, anything to comment on this?
Why do you ask for history of fever, Basha?
Fever, why fever, Bipasha?
Sir, fever may be due to any infection, like due to in acute mastitis there may be high grade of fever, but there may be also fever in carcinoma also.
Why?
Why?
Sir,
Why? Sourav, you can take you the answer. We can help her, no problem.
Sir, in case of carcinoma also, there may be localized rise of temperature due to the inflammation of the tissues involved.
Why inflammation occurs in a tumor?
No, fever. We are talking about fever.
Neoplastic condition, no?
sir, tumor necrosis. Sorry, sir. So tumor necrosis factor beta and IL-1 maybe it's increased
they will have pyrogenic response. So that's
Yes,
what
sir.
Agartala wants to answer, why fever. Okay. So we'll go to the next slide, sir.
Yes, sir.
Okay, next slide.
uh,
Past system, any such swelling? Why any such swelling in the past? Why you asked that?
Sir,
About
due to it may be due to cyst also, which recurrent cyst or recurrent mastitis can present also like this way, or any abscess.
Okay. Why is oral contraceptive pills and hormone replacement therapy significant?
Yes, sir. ACP and hormone replacement therapy contains estrogen, and we know that estrogen exposure is the main cause of breast cancer.
Okay. Any hysterectomy history is significant or just like you asked?
Sir, just like we asked, but it may be associated with bilateral salpingo-oophorectomy. We don't know about that. If bilateral salpingo-oophorectomy has done, then it may be associated with HRT replacement. But actually, the patient don't know about the HRT therapy or can't tell about exactly what it is. So that's why I have just added it.
We'll go to next slide, sir.
2 points I would like to add. What you have missed here, Bipasha?
Or what you have missed here? Answer sir's question. No, we can answer.
Always, the first thing you always ask about trauma.
Sorry.
So any lump in the breast is traumatic fat necrosis, one of the differential diagnosis, and any history of surgery, like prostratia.
Any such swelling you have told, you are not told surgery, because surgery may be
Fibroadenoma or a breast abscess, or whatever.
surgery for fibroadenoma maybe a risk
Anything which causes fibrosis will later appear like a lump which is hard. So
That
that
is,
really is normal.
important. So if you have trauma is important, as you have not mentioned, this is important. Okay.
Right. Next slide.
We'll get slide. Okay. Anything to comment is here for the year. Told everything here detailed. I think very nice is here detailed. Who are the viewers? I think full 3 generation families should be mentioned in breast lump, thyroid, and
What about the other siblings? Are they male or female?
Sir, two male and there are 4 sisters and 2 brothers.
Among 4 sisters, 1 sister got this lesion.
Yes, sir. Yes.
That you have to mention.
exact detail it is not
Well,
shared.
suppose all 4 sisters had lesion, what does it mean to you?
Sir, it's due to BRCA mutation. BRCA1 mutation.
Any carcinoma which affects the entire family? Are you aware?
Any about any syndromes related to this?
All
So this is important. Breast, thyroid, ovary malignancy, colonic malignancy may run in the family.
Yes.
And
Yes, sir, yes, sir.
colon malignancy patient may develop carcinoma breast. Ovary malignancy patient may develop carcinoma colon. Thyroid later carcinoma breast. Understood? So thyroid, breast, ovary, colon, then often interrelated.
The slide is nice, no? But only thing you have to mention that all entire siblings you must mention, male and female. Among the 4 sisters, one sister has got the lesion. Is it not? How old is she?
So at the age of 40 years, she got the lesion, and now she is 50 years.
50 years and on homeopathic treatment.
Yes.
And something about the BRCA, Bipasha, you know about BRCA?
Yes, sir. Sir, because she got the lesion at the age of 40 years, means my patient's relative got the first degree relative got the lesion at the age of 40 years, so we can go for BRCA. Yes, so we can go for BRCA genetic testing.
Okay.
What does BRCA mean? Yeah.
Form of BRCA? Saurav?
So it's the breast cancer gene, BRCA1, BRCA2, there are 2.
BRCA 1 and 2. What is the 1 and 2? What is the difference between 1 and 2?
So one,
Okay, so one is present on 17th chromosome, and the BRCA2 present on 13th.
Okay. So one
And
male,
also
one
the BRCA2, yes, sir.
in the male breast, male it
Breast carcinoma.
Yes, BRCA2 is more associated with male breast.
Okay.
Good.
You have found few syndromes that are mainly theory actually, Cowden syndrome, Wolfram syndrome, all those things. We are not going to detail those things, you can always read about it. But detail important thing is, I think, sir is highlighting detailed family history is very, very important. So 3 generation of family, how many of them, and little bit it will also may have your economic backup also. So that you will have the idea what they are working, how they are doing, so that you can have economic backup, so that you can plan your treatment. You know that any emergency treatment costs a lot unless there is a government support for individual. So that also you have to think. So family.
Remember the first degree relatives, mother, and mother, sister.
Her siblings are what exactly, are there any problems with them? So that also important. How many siblings for mother?
So first degree relatives.
Related, their detail is important. Whether they have undergone any treatment for thyroid, breast, and so on, ovarian malignancy. So that detail. So family history is very, very important in the breast lump. Here I think some students like nothing significant. That word should not be written in breast, thyroid, and mass abdomen. You have to detail it, like we should draw the diagram, everything. Of course, sir, rightly.
No, I will ask about even grandmother.
Grandmother, 3 generations.
Grandmother and mother and her own family, mother, sister, and all. Then your family sister.
Detailed family history is very, very important in the breast lump. It was added points to manage the patient. Understood? So whether it's related, especially carcinoma breast. Okay. So that's important. They have written well, but all 3 generation detailed history, like Manoharan sir has rightly pointed out, in detail is important. Okay, family history. So we'll go to the next slide, sir.
Yes, sir.
Okay. Anything else to this one? OCP she has already told. Next slide, diet, bowel, bladder, chew spawn with tobacco, betel nut for last 45 years. So
Again, Bipasha, one critical point you have done, presentation is very good. What is the age of the mother during the first childbirth? That is very important.
okay,
I not mentioned it.
okay. That is enough. Okay.
Why is it important? Age of the mother during the first childbirth.
Sir, estrogen exposure, it also about the estrogen exposure. The earlier she got pregnant, like less than 20 years old.
No, we will give your history only. See, menarche at 15 years. Okay? Menarche. Age at first pregnancy is 19 years. That's good only, no? So that you remember that the important point.
Early pregnancy. Late first pregnancy is a risk factor.
Whether she has breastfed or not.
That's okay.
Yes, sir.
It's important. You are not mentioned there.
You not mentioned, no?
High pregnancy, 3 abortion, 2 children were there. Two children, how long she has
Whether
breastfed?
she has breastfed, and if not, if that, so if it is yes, then how long she has breastfed? What is it?
More than 1 year, 1.5 years, they will give a breastfeeding.
Breastfeeding, how long should we breastfeed to give protection?
Sir, minimum 1 year of age.
Approximate, 2 children, at least 2 years. 1.5 years to 2 years.
Okay, sir.
So breastfeeding point you have not mentioned.
Yeah, breastfeeding is important. That's the most important because breastfeeding is a protective measure for carcinoma breast. So that is the point which is missing. Sir is rightly pointed out. Thank you, sir. And that point students should note actually. In all breast lump, breastfeeding, how long should be mentioned. Always remember that point is important. So that is an important point, sir. Thank you. And we'll go to the next slide, sir. Anup, sir, anything to add on to next slide? Next slide. Sumisha, next slide. Okay. Treatment, no history of allergy. He has not taken any treatment yet for the present condition. So she has not gone to any other doctors or homeopathy or anything because one of the symptoms is homeopathy treatment, not I think. Okay, just summary next. Summary, put the summary. Right, anything to comment on this? And meantime, we'll ask Agartala. Anything to add on the history from your side? You want to add on to Sadhan? Sadhan is there. Devesh is there. Agartala, you can put your comment. Anything to add?
So, just one thing, Bipasha, when you said estrogen stimulation, you have to say uninterrupted estrogen stimulation. It's uninterrupted.
Okay.
That's a very important adjective that you have to add. But otherwise, yeah, well done. You did well.
Okay, Sadhan. Sadhan, you want to add?
Yes, sir, I'm here. One more thing, Bipasha.
Yes, sir.
When you said patient has 2 children, right? So whether you should have asked whether the delivery was full term or preterm. How is it important in this case?
Sir, the 2 children were delivered by vaginal delivery at term.
It was a full term
Usually,
delivery.
what happens in full term is there is a process in breast which occurs called as terminal ductal differentiation. That is a more protective phenomenon. So that's why in preterm labors, the patients will have more prone for, that means they'll have more risk for developing carcinoma breast. Okay. But other than that, you have mentioned everything fine.
Devesh, if you are around, anything to comment about history? Devesh is not there. Sadhan, yes, come to Agartala. Sir, Manoharan, sir. I think Anup, sir, not.
Nothing significant. The only thing whether it is a normal delivery or it is by section.
Yeah, that's what. Section normal delivery, whether it makes a difference, maybe. So, like Sadhan rightly told, it also will have some added effect if it is. Yes,
So that answers 2 questions like what Sir said. It is full time delivery, whether it is normal or she has delivered earlier than what is the premature delivery, and if it is by section, the ability to feed the child that will be impaired for some time. These are the issues you must know. Always ask for the nature of delivery, whether it is normal delivery.
Yeah, full normal delivery, better to tell full term normal delivery.
Full time normal delivery.
And full term, you better to add in.
That fulfills all the questions.
That's the thing important when you write personal history, mainly. Okay, so delivery.
Last line, ma. You read the last line. Your younger sister.
Yes, sir, her
Because I read the last line. Her younger sister was
diagnosed with breast cancer.
Sir, her younger sister was diagnosed with breast cancer 10 years back at the age of 40.
40. So you mean to say for 10 years she is without any proper intervention?
She's still alive.
Yes,
Yes, sir. Yes, sir.
She's taking homeopathic treatment.
She was
Yes, sir.
diagnosed with cancer.
Now that means she must be now 50.
Yes, sir. Doctors also advised her to take chemo, but she refused it and undergone for
10 years lady with the breast lump without any
Treatment.
any treatment means she is comfortable means what? Is it malignant or benign?
Sir,
Could be it is lobular carcinoma in situ or something.
It is one possibility.
no,
All things. See, when you say that she is a sibling and she has got a breast lump,
Otherwise you have to tell homeopathy is working.
homeopathy is working or allopathy is failing, which is the one. So 10 years with the breast lump, I think is too long a time, isn't it?
Too long time
To make the patient comfortable, by now she should have developed a lot of complications.
Yes, without any
Yes,
treatment.
yes, sir.
So still she is doing it, continuing with homeopathy means what? She is not having any difficulty. That's why she is comfortable with homeopathy.
Have you gone through a report, the sister's report, whether they have got biopsy?
Ulceration is there. She told ki ulceration is there, nipple discharge also there.
Okay.
Okay.
Okay, understood. Okay. So there's a point important. So whether it is really or not, how she is going on for 10 years without proper treatment.
So by now she should have ulcerated, fungated, the growth should have gone. You would have got at least early metastasis also.
10 years is a long.
10 years is a very long time. Anyway, we don't
Mostly it is benign unless it is
when
confirmed.
you mention it in the history, this kind of questions will come.
Yeah.
So the thing is, don't put that, you just mention it in orally. Don't write in the case.
And earlier she had told it's a homeopathic treatment. So
Yes.
see it going on with homeopathic treatment for last 10 years, how it is possible. You just think. So it's most of the things we have discussed, I think, in history.
Yes, sir.
Discussed about syndrome, BRCA, family history. You have rightly mentioned a few other points, breastfeeding, which you have missed, sir. And Sadhan mentioned full-term normal delivery has to be told. And uninterrupted estrogen, that's what Tala is rightly, properly pointed. And other things, of course.
Trauma.
Trauma, yes, not mentioned history of trauma. So these are the things which should have been added. Otherwise, it is okay, sir.
Nice history, sir.
Thank you, everything. So we're going to do presentation, sir.
Yes, sir.
Okay, we'll go to the presentation. Next slide, Subisha. Okay, Sourav, you are presenting.
Yes, sir. Going for the physical examination of the patient, we did the general survey or the general examination. For the head to toe examination, it was normal in the sense that we are excluding the examination of the chest and all that when we approach the patient. And we checked for the tears, cyanosis, clubbing, edema, and lymphadenopathy. We checked for all this, and all these were negative. There was no positive history of this. We checked for the vitals. We checked her axillary temperature in the left axilla, which came out to be 100 degree Fahrenheit. That was, she was having some mild fever. And her blood pressure, we checked in her supine position in the right hand. It came out to be 116 by 78 millimeters of mercury. We measured her pulse in both the hands, which came out to be equal, rhythmic, 82 beats per minute, and there was no radial delay. We could not actually check for the radiofemoral delay or that. In the respiratory rate, we had gotten it to be 17 breaths per minute.
Okay. Next slide.
So much of medicine related. Sourav, you are tuned to the. All undergraduates are heavily tuned to the medicine. We are not interested in radiofemoral delay. Why should we check in both arms?
It's a goal of because they are
Much of we are patient is alive, we are very happy. Patient is having fever, mild fever, very significant. Maybe on the day of examination, she had fever.
okay.
Continuous fever is significant. Here in this previous side, which is the only important thing we are interested. It will make the
So, from your extensive general physical examination, what is the most important thing that you have missed,
We'll go back.
or something that we are interested in? I think it's a very extensive physical examination, but what is most important or relevant? What's the BMI? Does that
Oh,
make
yes.
any difference?
If you have obesity, then there is could be more.
Exactly. If they're obese, the risk of breast cancer increases, isn't it?
Obviously, it's a risk factor.
Your only point is, Sourav, respiratory rate is 17, that is normal.
Yes, sir.
That means lung is not involved.
Yes.
Understand? This is what significant for us. This all these things, rhythmic, E equal on both sides, no radiofemoral, all delete. I think you are a good student for medicine respiratory case, not for surgery. Understand? So respiratory time, not so much. A patient is alive, what is his temperature, pulse, BP, So respiratory system, type A means something wrong.
Still having temperature, sir.
Sorry. Yes, sir.
That day or even now she is having temperature.
When you are
No, sir. Yes, that at the time we examined only then it was like that. We had asked her if she had any complaints of fever, but she did not have any such complaint of fever.
So I think Sourav had temperature that day.
okay, you have to finding, let him have, sir. No?
Proceed. Next slide.
Next slide. Okay.
So, going with the local examination, it is examining both the breasts. In the inspection, we notice a swelling in the right breast, in the upper inner quadrant, as well as the upper outer quadrant and the lower outer quadrant. We asked for we had actually examined the patient in a semi-recumbent position, and also in a lying down position. As we go further, we'll see. In that case, when we examined the patient, there we can see that the breast on the right side, the nipple level of the nipple is not corresponding to the level of the nipple on the left side. So there is failure of the right nipple to fall away from the chest, and the left breast is quite displaced downward and outwards. The right breast is larger compared to that of the left breast, and the nipple has been retracted in both the breasts. We asked her if this was a recent complaint or a recent observation, but she had said that it is since her birth. So maybe that was a case of congenital retraction of the nipple, and there is no complaint of any discharge from the nipple, and no ulcer over the nipple and the areola also.
Next slide.
Continuing with the inspection, the size of areola was 2 into 2 centimeters. There is no noticeable decrease in size due to retraction, or no cracks or fissures or ulcers or eczema is noted. There is no discharge as well. There are no scars noted, no engorged veins, no pigmentation, and no redness or shiny appearance of the skin. No skin changes have been observed. The swelling or lump in the right breast, in the as I mentioned, in the 3 quadrants, and surface is smooth, and the margin is irregular. Next slide. No edema is noted in any of the sites, and inspection of the breast with the patient sitting and leaning forward was done, and the right breast was not falling forward equally against the left breast. And inspection with sitting and pressing her waist with the hands, no skin changes were noted on any side. Inspection with the arms raised over her hand while the arms would touch her ears, no visible lump or skin changes in the left axilla, but on the right axilla there is one lump which is around 3 centimeters in the largest diameter. It is a globular mass. There is no redness, ulceration or scar, no visible pulsations over that mass, and the left breast on inspection appeared normal. In arms, we did not notice any lymphedema or no restricted arm movements, no surgical scar marks. In the supraclavicular fossa, there was no lump or fullness, and there are no skin changes in the arm. There were no skin changes in the arm. Then going with the palpation, we palpated the left breast first, and then the right breast was palpated. A 5 into 7 centimeter lump was palpable in the upper, outer, inner and lower quadrant. It was warm to touch by the dorsum of the hand. It was non-tender and with a smooth surface and hard consistency. The margin was irregular, and it was fixed to the breast tissue, fixed to the skin, but not fixed to the pectoralis major muscle and against the chest wall by palpation. As you can see in the local examination, I have just made a tabulated chart out of this. the consistency hard, there was no ulceration. The illumination test was negative for the right breast. That is in the breast in which we found the lump. There was fixity to the skin, but there was no fixity to the chest wall by palpation. And by palpation of the axillary lymph nodes, we found the level 1 nodes being palpable in the right axilla. And we measured the size and palpation of cervical lymph nodes. There was no palpable lymph nodes in the right side, and in the left side, everything was normal. There was no lump, and we had not we palpated for the lymph nodes, both the axillary group and the cervical group of lymph nodes, but there was no palpable lymph nodes in the left breast.
Next slide, Vishnu.
And in the swelling, as we describe it, is having a smooth surface, hard in consistency, and irregular margin, not fixated to pectoralis major or latissimus dorsi or serratus anterior, as we check for it.
Next slide.
I had drawn the findings of the case. In the right axilla, the level 1 group of lymph nodes are swollen, and in the right breast, as you can see in the 3 quadrants, there is a swelling involving these 3 quadrants, the upper, inner, upper outer, and lower outer quadrants. And in the left axilla as well as the left breast, there are no findings. There is a picture of the skin fixity that we have tried to assess. It is actually for the left breast. In the left breast, the skin was pinchable and it would come out. There was no skin fixity, but in the right breast, over the swelling, there was fixity with the skin.
Next slide.
In the examination of the lymph nodes, the level 1 lymph nodes, as assessed, were palpable in the right axilla. The lymph nodes were not palpable in the left axilla, and the supraclavicular lymph nodes were also not palpable.
Next.
In the systemic examination, we heard normal vesicular sounds, and there were no added sounds. There was no pleural effusion. In the abdominal examination, we could not palpate for any ascites or any free fluid. And in the spine examination, there was no deformity. She could sit up straight. There was no complaint of any tenderness or paraspinal spasm. The movements are normal, and in CNS, the reflexes were normal in that case.
Next slide. Okay.
As we go towards the summary of the case, going to the brief history of the case, the 64-year-old postman was late.
Sir, you tell the examination part.
Okay, sir. On physical examination, the general survey is essentially normal. On local examination, the left breast is normal. The right breast is asymmetric. There is retraction of the nipple. It was on both sides. The lump is fixed to the skin, and there is no discharge. The swelling is found to fill and fixed to the underlying chest wall. On the right side, there are multiple axillary lymph nodes that are palpable, the level 1 lymph nodes, and no supraclavicular lymph nodes were palpable. The systemic examination was essentially normal.
Go back to the inspection. Still go back. Okay. Next slide. Sir, first slide, anything to comment, sir? Right breast, upper, inner, outer quadrant, yes, lower quadrant.
No, as I said earlier, the pictures you have to put the patient sitting straight. Understand? It is a tilted picture, so that's why you are not able to make out the contour of the breast. You said right breast is larger. The picture is the right breast is more in the front towards the camera, and as it looks augmented. Understand? The picture has to be both breast must be straight sitting so that you can compare the level of the nipples and the other things with the fullness in particular quadrant, which is bigger, smaller, and all those things.
Yes, sir. This why retraction on the opposite nipple? Is it recently or it was there?
He has mentioned since birth he is told.
This was since birth.
So what is the message you want to convey?
Also, it's a congenital retraction of the nipple.
But the point is retraction of nipple. What is the take-home message you want to tell your friends?
So that is because of the swelling, there has not been a retraction of the nipple.
What is the reason for retraction? Reason for retraction.
What's the reason for retraction? The congenital one.
Sir, due to involvement of Cooper's ligament and also the breast tumor, also the pulling the.
Malignancy, yes, that will get involved to contract.
What comes out of the nipple is milk, so that is a lactiferous duct which is involved. That is why the nipple is retracted. Okay. Second thing is take-home message is very clear. Unilateral retraction is significant.
Yes.
Understood? Then the reason retraction is significant. Here both are not there. Both bilateral is involved and it has not reached. It is there since long time.
It's both sides since a long time, is it?
Long time. That's what he said.
So it is not probably not due to carcinoma. It is there because bilateral.
But the contradiction is you said she is married and has 5 children or 4 children and she has breastfed.
Yes.
No, sir. She has 2 children and
Did she breastfeed?
Yes, she said she is breastfed.
How without a nipple she is able to feed?
Is it the retraction or inversion? Because
Sir, I think inversion.
it's the inversion.
So, you understand, Sourav, Bipasha, that has to be very clear. You said the patient has 3 abortions, 2 children, she has breastfed for 1 year, 2 years, you committed. When bilateral retraction is there, how the woman will be able to feed?
Feed the child. So that's
These are all things you are contradicting yourself, you have to be little careful.
it must be nipple inversion.
Inversion probably.
Inversion, it is not
Or at
retraction.
least on seeing the patient, you should have the doubt how she is. We should have asked the patient whether she breastfed means out, whether she
So
has.
if you have asked the breastfeeding detail history, how you could feed.
How did you breastfeed means she would have told.
Then you would have told that because while feeding it comes out. While child sucks, nipple comes out. It means it is an inversion. It is not a retraction. Understood? So mostly it is so breastfeeding is again comes a detailed breastfeeding comes very practical here in this patient specifically.
Especially with this patient with the nipple retraction.
Bilateral nipple, it's a nipple inversion. Cannot
Next slide.
understood the difference of Bipasha?
Yes, sir. Yes.
I think you have to understood, okay? So next slide will go, sir.
Yes, sir.
He said, breast is not falling forward, you have told, no, sir?
I was waiting for it.
Okay, sir.
Yes, tell me, Sourav.
You told me.
See, you say one statement and you are contradicting yourself.
You
So
said
you said it is not falling forward. That means something is holding it behind. And you are telling it is
Yes,
not
sir.
fixed to the muscle, it is not fixed to the rib and all those things.
It's a bit-
Nothing is holding it behind. Why it is not falling forward?
why it is not falling forward? If it is something is holding
At least tell me what is falling forward.
Sir, in this position with her hands over her thighs,
Which position?
sir, in sitting position,
Leaning forward, bend forward.
leaning forward. Yes, sir.
Only in that position, both the breasts will come forward and hang.
You are leaning forward.
So affected breast is not hanging because something is holding it from behind. What is the structure behind the breast?
So what is holding behind? You have asked somebody, chest wall is not involved, you are told. Nothing is involved.
Yes, yes.
Muscle is involved.
The two things you said it is not falling. At the same time, you are telling you can't technically writing that it is not fixed to the muscle, it is not fixed to the rib, chest, sat at the side.
I don't know, mobility, you said mobile, it is mobile.
Mobile also you said.
Without
Yes,
contracting the muscle, it is mobile.
Yes, it was mobile.
Including the muscle in the contraction also, you said it is mobile.
After contracting the petrous major muscle, it is mobile.
Yes, sir. Yes, sir. It was mobile.
Then why it is not falling forward? Tell me.
Why it is not falling forward? So, understood why it is.
Bipasha, you understood
Yes, sir.
what is behind the breast?
Sir, I think due to the tumor,
No, just answer simple straight question. What is behind the breast?
sir, Cooper's ligament. Yeah.
Pectoralis major.
Fascia, pectoralis major muscle.
What is behind the pectoralis major? Pectoralis minor. Okay.
Yes, sir.
What is behind the
Yes, sir.
pectoralis minor? Pectoral fascia. Then what is behind the pectoralis minor fascia? Your rib.
Ribs and chest wall is there.
Rib is otherwise called costum. Costum. Anatomy, forgot. What is the muscle between two ribs? Intercostum.
Intercostal.
Third one is the muscle covering the ribs in the serration. That's why it is called serratus anterior. So that is chest wall. So to get chest wall fixity, first of all you must penetrate these muscles, fascia, and then reach the rib. Understand? When you say not falling forward means at least it should have got infiltrated into the pectoralis muscle. That is called muscle fixity. Later on, chest fixity. Now you tell Sourav what it is fixed to.
Well, because we have not examined.
You have signed in your declared document that it is not fixed to the muscle, it is not fixed to the rib, it is not fixed to the serratus anterior, but it is not falling forward. So we are curious to know what is holding it from behind.
That's what. So somewhere not correlating.
You want to change?
Sir, yes, in my observation would be that it is actually involved with the that is, it is fixated with the chest wall. There is chest wall involvement, but my technique of
Again, you are doing the same thing. Whether it is muscle fixity or chest wall fixity. That's
or the chest wall fixity. Sorry, sir. Chest wall fixity.
chest wall fixity means it cannot be mobile, no?
Is it mobile?
You only said putting the muscle into contraction which is mobile.
Sir, my examination of examination technique must have been wrong. Because of that, I.
No, because what you felt, because we are not sure, we are not examined the patient.
Bipasha, help your friend.
Sir, I think due to tumor involving the skin, like we have also seen that skin pinch test also.
That is different. We are not talking about skin. We are talking about the growth going behind.
Skin involvement you have already told, we accept it. We are not questioning that. You have marked it everything perfect.
Tumor will grow on all directions, no? Not only towards the skin. We go behind also. We go
Yes,
in
sir.
muscle, minor fascia and rib.
Yeah, confusion is whether chest wall is involved or not, muscle is involved or not.
We are not worried whether it is chest wall fixed also, but you are telling categorically it is not falling forward.
It is not falling forward. Why it is not falling forward? If it is not
Sir,
involved.
there is no involvement of a chest wall, because if the chest wall was involved, then that lump was not mobile. I think that this lump is involving the muscles like pectoralis major or minor.
How do you test whether it is fully involved or just it is holding? Putting the muscle in the contraction. Putting the pectoralis into contraction. So if you check without contraction whether it is mobile, then ask her to press the hand and put the muscle into contraction and again check for mobility. So you call it restricted mobility or it is not mobile at all. So that point has to be very, very clear. Understand?
Okay,
Sir, have you contacted the muscle, pectoralis major muscle and checked?
Yes, sir, but I was not very sure with the. I just checked for the mobility, but I was not sure with the margins that I was holding. I was not very sure of the examination.
See, before putting the muscle, probably it was mobile, let us assume.
Yeah.
When you are putting the muscle into contraction, there will be little mobility. That means restricted mobility.
Any mobility is there? Not. That's the point, sir. Is asking.
Either it is not mobile or limited mobility when you put that in.
Limited mobility. It is limited mobility.
That means what is the meaning? It is attached to the muscle.
It is infiltrating or involved in the muscle.
That's why there is restricted mobility.
Sir, I have a question. In
Yes,
case,
yes.
yeah, I'll be very honest that I was not very confident with the palpation that I had done for the swelling.
No issues. But only thing is you must understand what you are talking. That's all. Simple.
Yes, sir. Yes, sir. In that case, sir, as we see from the observation that it is not falling forward equally. Should we just mention it? It is chest wall involvement or
It is
muscle?
not falling forward equally means something is holding behind. That's what I said all this time.
Yes.
So you check for muscle fixity. Ask the
must be chest wall.
move a lump across and see how it is mobile.
Erectus anterior also part of chest wall.
Then you ask,
No.
then ask them to press the hips, put the muscle into contraction, again check for mobility. See whether both are same or difference is there. If there is restriction, you will know that it is limited. Then
Have you checked the erectus anterior?
how will you put the
Yes, sir. Yes, sir.
how
How will you put the contraction? Because you have
Sir, it
all
was-
three quadrants are involved. It is quite big lump as far as you is considered. It is involving more than one quadrant. Actually, 3 quadrants is involved. You are told.
Yes, sir.
upper outer and lateral, upper outer and lateral also. So there is chance that it involves the which muscle? Sir is asking.
Because lateral also which muscle may be involved. Lateral dorsal and simple anterior. Simple anterior.
Yes, sir.
Yes, sir.
So how will you check
Yes,
that?
sir. Sir.
How will you check it?
Sir, we'll ask the patient to place her ipsilateral hand on our shoulder and then to straighten it and then
Over the wall, you have to
All is why you want Sourav to give shoulder.
over the wall.
Over the wall.
Both sides you have to push. Both hands.
Both hands should press on a wall and see the muscle will under contract.
Extended elbow.
Extended elbow.
Over the both hands like this. Extended elbow. Over both hands like this. Extended elbow. Okay. Extended elbow. There is an extended elbow. Both hands over the wall. Then check the mobility. And backward dorsal is posteriorly push to extension against resistance. Only 3 things muscle you have to check: petrous major, lateral dorsi, and serratus anterior.
So chest wall is possible, but don't say always chest wall fixity. That comes last.
No, this question is valid, sir, because it is not falling forward means what they should say. Because
Falling forward means what? Nothing is holding behind. It is free, not attached to the muscle. That's all.
on the other hand, yeah, that's what on the other hand she is telling is mobile. So probably it is probably attached to the serratus anterior. That is why it is not falling forward. Even though you feel apparently you feel the mobility. Because if it attached to the ribs, it will not fall forward. And you will not get mobility also. So here the problem is they are telling it is mobile without contact with muscle, but it is not falling forward.
Even your subsequent slides you say this, even the summary you are telling it is mobile.
It is mobile. So it is probably because both of them have felt mobility, probably it is attached to the serratus anterior. That is why it is not falling forward.
Possible.
Not to the ribs. If it is the ribs, attached to the ribs, it will not be mobile at all. It is absolutely fixed. You won't be able to move the swelling. So that is the only interpretation we can think of if your findings are correct. That is the only way, because it is not falling forward, it is only still there. But you are telling it is a mobile. That is why Sir is very critical about these to not correlate with each other. So you need to justify it if it is so in this patient. If your findings are correct, then you can say only serratus anterior will not. That's why you feel the apparent mobility without contracting it. But it won't fall forward because it's holding behind. That's the only explanation. Otherwise, nothing. Otherwise, you won't be able to clinically explain, give a reason why this is so. That's why Sir is clearly asking. It is not correlating. That's why Sir is very.
Why you have mentioned no engorged veins?
No engorged means why? No engorged means why, and no engorged means.
Why is it significant? Yes,
so
Bipasha is silent. Yes, ma'am.
Yes, sir.
Why engorged? Why has mentioned no engorged veins? What is the significance?
Sir, due to mass effect, the veins may dilate.
No, simple. A breast lump with lot of veins who are running over the breast. What does it mean?
Yes, neovascular.
What is that?
So neovascularization is going on.
Diagnosis. Inspectory diagnosis. Yes, Sourav.
Sourav can. Sir, you can tell the answer, sir. There finally.
No, you please tell, sir. You can tell.
Sir, you can think and tell.
Yes, ma'am.
Because one is vascularity of the tumor, second thing is if there is a venous involvement, there will be dilated veins. Here it is not there. Understood?
Relax.
I think sir is looking for Mondo's disease.
Mondo's disease, sir is asking Mondo's.
Relax, ma. Cystosarcoma, relax.
Phyloid tumor is very common. I will see phyloid tumor.
Lump with prominent lobulated surface and veins. It is diagnostic of
Dilated veins is quite common in phyloid tumor.
the common things you must remember. Okay, next slide.
Next slide. No, this is anything to comment, sir. Infection, sitting position, pressing weight. That is again for Petrol's major, I think. Yes,
Yes, sir. Yes.
raising the arm, right axilla, lumpy as mentioned, globular, no ulceration. That is again axilla, arms raised, visible lump, left breast. Okay. Anything to comment in this? Nothing. Next slide. Next slide. There is no lymphedema, restricted arm movements. You ask. Why arm, no surgical scar mark you have looked for?
Sir, if the lateral in the arm, if there were the lymph nodes being swollen, then what I'm actually
Sir, surgical means we looked for because if there is a reversible surgery for lymphedema or seroma.
Okay.
Now, which side is the lesion now? Which breast is involved?
right.
So right breast.
Then you say right arm is none. Why you are telling arms no? That is a generalized statement, no?
Both sides.
Both sides. Opposite side is right side. You say right arm, there is no lymphedema.
There is no lymphedema.
Understood. Why you are talking about generalizing both arms? There is no this thing. Both supraclavicular pressure, there is no lump. We are interested in the right arm and the right supraclavicular pressure. Understood?
Yes.
Right.
Yes.
Okay.
Also yes in the arm. Okay. Specify which side, important. Because we are looking at the right side. Okay.
Next slide.
Okay, next slide. Next is okay. Left bit, okay. Margins are fixed to bed. All these things again we are discussed now, sir. Chest wall not fixed to the petrous major muscle, chest wall, all these things points we have discussed. Let's say we had a controversy here, so now we point is clear, no three muscles.
You have marked the size of the tumor, so huge mass.
So very quite large it is, almost 3 quadrants occupying.
Possibly, definitely it would have been involved in the muscle. Definitely. Chest wall we don't know, or it may be serratus ended. We are not sure.
Large muscle involvement is most likely, more likely.
Most likely. Okay. Right. Next slide.
Next slide. Okay, these are you have again same thing you have put in the slide actually. This okay. Why you put transformation?
Point number 8. Is it significant? Is it
Transformation, if you are thinking that's cyst, yes, otherwise why it is important? Why you want to think of transformation?
Is it cystic or does it contain fluid?
So it was the solid mass. There was.
Then why you put transformation?
Transformation, if you are suspecting breast cyst, fluctuation is there. So anywhere you do transformation when there is a fluctuation.
Okay.
Unless you think of tensely cystic swelling where it is more
Rare, very rare.
rare, and especially rare it is in the breast cyst. Understood? So that's why it becomes transformation.
Unwarranted. So you put that and the pain.
Then all breast cyst, what are the types of breast cyst, so everything they ask. What is all those things you have to learn and you have to tell. In fact,
Soft, as I have said, rightly cystic and fluctuation positive, then you think about transformation. Otherwise, that point is not applicable here.
blood good cyst, what is blood good cyst? Heard about it?
Yes, sir. Cystic, fibrocystic disease of the breast.
One of the cyst will enlarge and forms a cystic swelling, palpable clinically. That is called cyst of blood good or blood good cyst. Absolutely right. So all this will come in the discussion on Tuesday. In this patient, not necessary to mention transformation because it's not fluctuant. Unless there is fluctuant, you won't be eliciting transformation. Okay, right? We'll go to next slide, sir.
Yes, sir.
Next slide. Tala, you want to comment anything?
Yes, sir. Sorry, I might have missed this, Saurav. Could you tell me in which position did you examine this breast? Recumbent, semi-recumbent, or sitting?
Sir, we had checked it for in semi-recumbent position, maybe.
Okay.
In a semi-recumbent position. Okay, you are happy with that also? You want to add on to anything else, Salah?
But does it matter, Saurav, if you put the patient in recumbent, what happens? If you examine in recumbent, is that wrong, or is it semi-recumbent that's the universal standard?
No, sir. In recumbent position, we can't inspect correctly because the breast uterus bulb could be falling over on the sides in the recumbent position.
Okay.
Yeah.
That is sufficient. Okay, semi-recumbent not while inspection you can do that, but eventually in the sitting position is sufficient actually. Okay, right. So Tala will move on to that. This is the same thing they are showing, sir. Next slide. So the diagram I think is okay, but he said single lymph node or multiple lymph node, right, Angela?
Sir, single lymph node.
Single group of lymph node that is.
Nodes that is which are attached to each other. Or
I felt node was attached to each other.
attached to each other. Okay, okay.
The diagram size of the lump is smaller than what actually it is.
What actually seeing is diagram, little more, it is wider.
You keep the photograph next to this diagram and see for yourself.
Bigger than this. But otherwise, it's nicely represented. I think you should learn to draw the diagram always. In all cases, you should draw the diagram. Maybe mass abdomen, thyroid, breast lump, or examination of piles or anything. Draw the diagram and express it to be very clear. So learn to draw diagram always. So it may be little bigger than the what exactly you are seeing, but better to put in a diagram always like this.
I will mention the dimensions of the lump.
So 3 into 4 centimeters. It was 3 centimeters into 4 centimeters. Somewhere I mentioned it.
Definitely bigger.
It's bigger than
Breast lump, sir, breast lump 5 into 7 and axillary lump was 3 into 4.
axillary lump they said 3 into 4 centimeter. Breast lump is 5 into 7.
5 into 7.
Okay, I'll ask you some basic question. 5 into 7. So when you do for TNM class stage 8, which you will take 5 or 7?
Sir, single largest diameter we should consider.
Very good.
Minus the diameter. And we will take as a require this one.
Whether it is horizontal or vertical, take the largest diameter or the tumor size. Okay.
Absolutely right. Okay.
Next slide.
So next slide, I think you will appreciate their diagram, sir. Even though,
Yes, sir, very nice.
because you will learn to draw diagram for whoever viewers.
Yes,
You should learn to draw diagram whatever.
Again, see, the patient is not in all tilted position. Patient is bent forward, again actually not bent forward. So photographs are taken, but only thing is to ensure that both the breasts are in the front and you can see and all the components in the position.
First photo is okay. Second one is patient is leaning forward. Okay, diagram is there, the same thing. Okay, next slide.
Next slide.
Next slide. Lymph nodes, you said one level 1 lymph nodes are palpebral node. You said nodes are attached to each other. That's why I asked whether it is they are attached to each other.
Single node is enlarged
Attached to each other makes difference, no? As far as the end staging is considered.
Yes.
Or you feel the surface is smooth or nodular of this lymph node area. You feel the single node or multiple nodes attached to each other.
So it felt
And you said only level 1, that's a burst level, but better to mention in the axilla anterior or central, I think, no sir?
Yes, sir.
Better to mention whether anterior or central, specify further. Level 1, whether it is anterior, which one is the level anterior pectoral lymph node or central lymph node? So,
anterior.
anterior, pectoral lymph node, anterior, okay.
Is it mobile or not? That you have not mentioned.
Mobile.
It's mobile?
Yes, sir. But
It is mobile, not mentioned, not
You have to mention.
You have to mention non-tender, smooth, no, you said smooth, not nodular. Non-tender, smooth, hard, mobile, not fixed to the skin. Okay? That's why exactly you explain. When you not what you say, you explain. Of course, size you have mentioned. Okay? Explain in detail about those lymph nodes. That's important. Okay? Right, if not palpable left axilla, septal lymph nodes are not palpable. Okay, great. Next slide. Systemic examination. For why you wanted to do systemic examination?
Sir, because of the suspecting the spread of the tumors to the various groups.
Clinical metastatic outcome.
Yes, sir.
Clinical metastatic outcome. Agreed. So, Tala, next slide.
Yeah, Sourav, what examination are you doing in this photograph?
Sir, actually, sir,
Looks like your exam
Now related to this, we will
is
continue.
systemic examination. Yes.
Yes.
Palpation maybe.
it was sir, checking for the we were checking for the actually regularity or the irregularity of the mass through the palpation, but this photo is not matching with the.
No, we are not matching to this, and we have put it continuously because otherwise sometimes what happens, the image will be there only one slide. Then we won't. That's why it is put that way. Because we started putting images in every slide so that
Feel for irregularity, you have to feel with the palm of your hand, not with your fingers.
Yes, sir, it's not fingertips.
You have to feel irregularity or surface with the palm.
yeah, surface of the palm, that's whatever. Irregularity you have to feel like that, correct. So next slide. Subisha, next slide. Okay, somebody she has told, he has told actually, all these things that we have discussed, the chest walls are rightly told, 3 muscles are important, chest fall, falling forward, and nipple direction, skin involvement, lymph node, better to mention which type, not just level.
Here, it is not mentioned whether it is mobile or not. Here also.
He has not mentioned mobile or not, then understood. System examination anyway you have told. Tarla, Sadhan, anything to add on to these things, anything you want to ask? Both
Nothing, sir. Sir, nothing, sir, nothing. It's fine.
Sadhan, you can put on your camera so that sir can see you. Tarla knows you anyway. Okay, no problem. Camera is not on.
Yes, sir.
Okay, no problem.
No, paranormal you must mention about whether it is any mass palpable parietal.
He has mentioned, sir. Parental, no near, no ascites he has mentioned.
That has to be.
All the other things he has mentioned. So there are certain things which is not.
Did you examine the spine?
Spine he has mentioned. Go back.
Yes,
Go back.
This is exam.
Yeah, spine he has mentioned spine. Tala. This is important. System. The spine is most important, like Tala rightly told, because commonest bone involvement in the carcinoma breast. Commonest, whether it is the bone, commonest bone is spine. In that lumbar spine. So spine is very important for this thing to mention. Always separately you have to mention spine. It is not sufficient. Normal.
What movements do you examine in spine? What movements do you look for in spine?
What movement specifically you look for?
Sir, whether she can sit up straight and she can bend forward, she can turn sideways.
No. Movements are forward bending and extension, lateral flexion, lateral bending, and rotation. Now, which movement is more relevant? That's what Govt is asking. Which movement is more relevant in that?
Sorry, sir.
No. Sadhan, I think you want to answer.
Rotation movement, you should make sure that the patient's pelvic girdle is fixed. It should be examined in sitting position. Okay.
That's important. Rotation movement is most important in the spine, and you have to make the patient to sit. Otherwise, in standing position, with the composite movement of pelvic girdle and spine. So make the patient to sit, so that pelvis should be fixed. And then rotate. What I think, Sadhan.
Yes, sir. Yes, sir. Correct. Right, sir. Right, sir.
So this is important. When you examine the spine movement, rotation is very important. Patient should be made to sit in a stool. Then the patient rotate. Otherwise, it will be composite movement of spine and pelvic girdle. So you won't be able to get the spine rotation movement. So most important movement is rotation, which you have to remember
Rotation.
in the exam. Okay, otherwise things are okay. Tala, they have mentioned.
Yes, sir. Right, sir. Yes, sir. Yes, sir.
Okay, next slide.
Yes, sir. Happy with that.
Okay, next slide. Anything? Deresh is around. You want to ask anything? Question? Deresh is left, I think. Sadhan, sir.
It's not there.
Sir, we'll go, sir. Most of the things we have discussed, sir.
Nothing.
Examination, like other things, axilla, opposite axilla, I think opposite axilla, And I think anterior group, they should mention anterior group. Level, in the length they mention level, but here group better to mention. Next slide. So what's the diagnosis, Saurav?
This is the case of carcinoma of breast in the right breast with a clinical staging of T3, N1, and NX because the
No, MS is not there now. The MS is removed from the NDC staging. Breast don't put complex. In the indication MS is not there. M0 you put. Okay. M0 MS is not at all, there in the NDC. For breast MS is not there. Other condition it is there. Okay. So T3, why is it T3?
Sir, because of the, I just considered the size of the tumor because I could not properly assess the mobility as well as the fixity of the tumor. I did not put it.
Okay, N1?
So only one group of lymph node was involved.
M0 it should be. There is no MX in carcinoma breast. NF.
Okay.
In other pregnancy, carcinoma but MX is not there. Remember, it's removed. Okay. So, sir, anything to comment on this? Tama, Sadhu?
So, is it early or locally advanced according to you?
It's early or locally advanced?
Locally.
No.
Sourav says early, Bipasha says locally advanced. Who do we go with?
No more voting.
Bipasha, early or locally advanced?
Sir, locally advanced because the size is more than 5 centimeter.
So, T3 is always locally advanced, sir.
Oh, sorry.
There is no confusion in that. Understood? Size itself is it local advanced. And more that you said it is kidney involved. So what it becomes?
It
It becomes T4
Becomes 4B.
4B.
1B. You said kidneys involved, you marked it. So it is not T3, it is the T4B, T4 1B. Understood? I think T4B I think Sadhan. No? Skin involvement.
Yes, sir. Yes.
So you have forgotten skin involvement what you are told clinically and you put it as a
Actually, sir, we had a discussion regarding that.
Yes, sir. Sir, actually, I have a confusion about this. Sir, I saw just that if the skin involvement of ulceration or purely orange appearance or any nodules are there, then that cause the skin involvement. But if only retraction or dimpling, that is
So
not.
you said the skin is involved. You never told because you have marked it. You never told dimpling or tetany. Dimpling is there. You never mentioned about that chemically. You said skin is involved. There is a point we took. So you have marked how much skin is involved, how much skin is involved, how much wider skin is involved. Sir, any comment on this, sir? Because they said skin involvement. Then
Skin involvement textbook says only 4 points. One is your pure orange. And second one is your nodules, your ulceration and fungation. These 4 only is considered as skin involvement. And one rare condition, your inflammatory carcinoma, where you have skin edema.
yeah.
So these are the only skin. This puckering and tethering is not considered as skin involvement.
But
Don't say skin involvement if there is puckering and tethering. Okay, this other 4 is pure orange number 1. Then your skin nodules, ulceration, and fungation. Only these 4 are considered as.
That's right. But what about here? Skin involvement, skin is free or not? You could name
The skin is fixed, but purely orange appearance is not there.
Yes.
Okay.
As per photograph, there is no pure orange.
There is no photo. That's what. If ideally, you should use the micro lens you have used. Magnifying light.
There is no ulceration, there is no nodules, there is no pure orange. Nothing is there. Then why do you say there is skin
Involvement. You mentioned yourself involvement in there. That's why we took it as a point. Otherwise, keep quiet. If not involved, it becomes T3. So whatever you written could become alright. But whatever it is a local endothelial carcinoma, there is no confusion about the LGC.
Such a huge size, if skin is involved, definitely she would have had PDRN by now.
PDRN by now. PDRN is not there.
It's not there at all. That is phase 3.
So it is a T3N1M0.
M0.
The local endothelial is LECB. Okay. So that is a clear-cut clinical diagnosis. Okay.
Yes, sir. Yes,
So
sir.
next slide will go, sir. Next slide.
Yes, sir.
So you said triple assessment. Okay. True-cut biopsy of what?
So true-cut biopsy of the breast tissue.
Tumor. Okay.
Tumor.
Tumor.
What is the other name for true-cut biopsy?
Core needle.
Core cut.
Core needle.
Biopsy.
What is the size?
Sir, 14 watts.
So how does it differ? How does it differ from FNAC?
How it differs from the core cut?
Sir, yes, sir. Yes, sir. Sure.
So in FNAC, we can check for the we can take only samples of cystic tumors, but in case of core cut biopsy, core needle biopsy,
What is the expansion of FNAC?
So fine needle aspiration cytology,
Cytology means what?
cell studies.
Only cells you will get.
Only cells will get. Here what will get?
You will get tissue. Tissue will get.
Which is better? Tissue or cell?
So tissue is better.
Which is better?
The main difference is FNAC can straight away go with the IM needle. True cut you need an incision. If needle is bigger, you need an incision for introducing the true cut.
Small incision, then you have to call it.
Incision you have to make and
Tissue is always better. Why tissue is better than the FNAC? Why core cut, true cut is better, core needle biopsy is better?
Sir, we can access the invasion, we can do the immunohistochemistry, we can let molecular testing.
Here status, we can get the grading also. So you can plan the treatment, you can strategize the treatment fully because you know the status, marker receptor status, grading, everything. And we are testing this, you have a staging also. So which stage it is and the metastatic is there or not. So T3 you have to do the best stage. T1 early stage may not do, but here as per guideline best stage is accepted. So in this patient T3 and 1 best stage also have to be done. True cut biopsy or core needle biopsy, definition the lymph node. Okay. So next slide, treatment. So neoadjuvant therapy, MRM, adjuvant chemotherapy later. What neoadjuvant therapy?
Sir,
what is neoadjuvant?
yes, sir. Sir, before surgery for downstage tumor and for micrometastasis and any secondary mets to any systemic sites, we go for a neoadjuvant therapy that contains adriamycin, cyclophosphamide, or then taxanes,
Okay.
4 cycles of AC or EC with 4 cycle of taxane in HER2 negative patients, and in HER2 positive patient we can go for taxane plus carboplatin plus herceptin with trastuzumab for 6 cycles.
Okay, no problem. How many cycles you will give? Neoadjuvant.
Sir, if it, yes, sir, if it is HER2 positive, then total 6 cycle. If it is
Neoadjuvant, how many cycles you will give and then reassess the patient? Here, neoadjuvant means you understood. No, you are completely secure the disease, not the palliation. So you give the you have to downstage and reduce. You have to prevent micromets. All those things. That's the concept. Then give chemotherapy. Usually 3 to 4 cycles. You give then reassess the patient with all evaluation, mainly breast, ultrasound, mammography, or whatever. Assess the MRI. Then assess the patient. Then you whether it is responder, not responders, how many also. I'm not going to detail. You can read it. Then go ahead with the MRI. Understood? So, sir, whether they should tell the breast cancer surgery is not possible in this patient. Sometimes they'll say should not be. Because all three parts did not, there is no role for, at least in this patient, breast cancer surgery. Ideally, neoadjuvant MRI. Then continue chemotherapy and hormone therapy. Okay? That's right. Treatment complete in this patient. They have told, they have written in neoadjuvant, but we more details they have told, but usually 3-4 cycles, I think, sir.
Yes, sir.
Yes, sir.
3-4 cycles.
Again, depending upon the tumor board decision, and second thing, the type of the tumor.
Yeah.
First thing in Tripura biopsy is the type of the tumor, whether it is ductal or lobular.
Yeah.
Then Saha rightly said grading of the tumor, well differentiated,
Yes.
undifferentiated. Then comes the your hormone receptors, ER positive, PR positive. Then comes the head. Okay. Then the only thing is this Tripura biopsy will tell you the type of the tumor only, and in situ carcinomas as well as infiltration and spread.
Yeah, in situ, then the invasive, it will become different. We are not going to detail it because of this.
What is latest only, even though as PGs, but UG should know. What is the other latest one which is included in the report? K67.
K67, they have
Proliferative index.
Yeah.
Now the report comes as it is. When you send the biopsy, the report comes as well.
K67 also included now. ER, PR, HER2, K67 together is included. So type, sir told type, grade, receptor status, K67. So the 4 things you have to remember when you check the tissue. This tissue is always better. Core negative biopsy is better. That's the point you have to remember. For lymph node, always FNAC, no true cut. Okay. So the point is true cut by the breast tissue. That's the point you should remember all this. So treatment delivery is okay. So sir, just go through my slide, sir.
Yes, sir. Yes, sir.
Anything to add on to Tala and Southern? Anything to add on to?
And one more therapy, last one you should mention is the radiotherapy.
Radiotherapy you should mention.
So after the surgery, whether margin is positive, based on your axillary nodal status more than 4, leave grade of the tumor, and all those things, the rest be taken into account for giving your radiotherapy.
Sumisha, next slide. Sumisha, okay. This from there, sir, we'll go to the my slide. Sumisha, go to the my slide. Quickly go to my slide. Sir, final comment, sir.
So they have presented very well, sir, I should say.
Definitely they presented
Both of them did a very well this thing. Sourav was little shaky. He retracted on his own findings. He said, I didn't know, I was not sure. Don't do that. So we agree with whatever he said. We are not finding fault with you. But you write a case sheet and you say it is this, and then later you again comment it is not at all fixed, and you say it is mobile, means you are contradicting yourself.
Yes, sir. That you should be able to do the reason, because he had a confusion about the test one.
I think you are more interested in telling about the unaffected breast.
Yes, sir.
If you are telling that breast is normal, that axilla is normal, that is not necessary. You finish this part first. Then go to the opposite breast side, the other right side breast is left side breast is unaffected, axilla and suprachoroidal, one line is enough.
They had a problem with the chest wall involvement, and they are confused chemically. It's a little tricky here in this way.
There is one thing called muscle fixity followed by chest.
Muscle is involved. That's the only explanation we can give.
So try to put the muscle into contraction, check for mobility. Take off the contraction, check for mobility.
Otherwise, their key sheet was good, sir, actually.
Very nice. Especially the family tree, your diagnostics, diagrammatic representation.
Where the viewers, I think, lot of
everything is on order. Very nice, very good, Bipasha and Sourav. That's good.
Discussion will be there will be problems and discussion because clinical analysis. Okay, they will learn later. Otherwise, good. They have presented very good case sheet. Definitely appreciable. Sir, I will just go through my slides for students. Next slide. So it's a very common long case for students, important in the exam. The areas a lot of questions will be asked. Short note and MCQs a lot of questions will come. So that's why this is important. Next slide. So male breast also sometimes not uncommon. Cytosarcoma fibers are already told cytosarcoma fibers are direct in veins. The explanation sir wanted is dilated veins. See that you can see the dilated veins in the cytosarcoma here. Lymph node involvement, fungation, nipple retraction. You can see inversion. This patient, what you had is about the inversion. Inversion differs from the nipple retraction. Next slide. Next slide. Chief complaint, orderly fashion, already you were told, swelling, pain, axilla swelling. In the order, if angular swelling comes first, then you can put like that. This is what you have to mention. Nipple discharge relevant to the secondary history. You already mentioned back pain, breathlessness, whatever CNS involvement. So this is the complaint order you should always in the case sheet. Next slide. So history, I am putting the table actually, swelling, pain, fever, already I mentioned. Time severity, why all the symptoms we have discussed actually in depression, deviation and retraction. Retraction is the inversion. Trauma, you have not mentioned, sir has actually told. Like due to the metastasis already we have discussed why, bone pain, weakness, paraplegia. Family tree, we have discussed in 3 generations. And breastfeeding is important. Breastfeeding is important. Somewhere I mentioned, I think breastfeeding. That is important. Breastfeeding and why, how she fed, how long it is also important. And that's actually sir has highlighted that point you have to remember. Breastfeeding, how long duration of the breastfeeding is important. So menstrual history, obstetric history, personal history already we have discussed. Diet, smoking, diet of course, estrogen, high diet, all those things. Next slide. So yeah, this is again breast examination, different positions. All of you know it is there in the book. Sitting position, 45 degree recommended. All clinical book is mentioned there. Sitting position, leaning forward, chest wall involvement, arms over the waist, shoulder fixity. Lying down position for self-examination. Some different positions that you have to remember. Maybe asked in MCQs or Viva they will ask. Or maybe small short note, different positions you should be able to remember these things. Next slide. Next slide. Next. This is a table you remember infection of both breast, size, everything whatever discussed. Nipple, areola, skin over the breast, Mondor disease. The another thing that term as highlighted earlier, Mondor disease, what are these things? Of course, dilated veins in the vascular tumor, and when the veins are blocked, and cytosarcoma phyloides and Mondor disease. That the 4 conditions you have to remember when you look for the engorged veins. Remember these 4 conditions. Swelling in the breast, infection, axilla, you mentioned, respiratory hypothesis, you mentioned, arm and thorax. Again, you have mentioned for the involvement of lymphedema, other things. Already we have discussed lymphatic and venous block differences. You can always read me in my book, it is there. So this table helps you to exactly how exactly instruct a patient, remember, positions, everything. Next slide. So palpation, again we discussed normal patient palpate. First you have mentioned that all quadrants should be palpated. And every time of the spines with the foraminal angle anatomy, they will ask part of the extension into the axilla, breast tissue is subcutaneous plane, whereas tendon spines is in the deeper plane, deep to the deep fascia. There is opening in the deep fascia that is called foraminal angle. That may be asked in the exam sometimes, so you have to remember that. So to examine that also important. And all the other things we have mentioned, petrous major, serratus anterior, lateral dorsi, how to examine, and skin involvement, what are the features, already sir has discussed this point, you have to remember. QD orange, ulceration, nodules, understood. Dimpling and tethering is not there, not the component. Location, fluctuation test, if it is fluctuation only, then check the concentration, the breast. Not in every patient, remember. Fixity, in tethering, fixity is there. Metral, all 3 muscles are important. Chest wall includes not petrous major and minor, remember. Ribs, epiphyseal muscle, serratus anterior muscle, but not pectoral muscles. Nipple areola are different. Nipple areola complex, how to examine. If there is ulcer, you have to examine the ulcer also. And axilla mentioned about the group to group, anterior, central, lateral, apical, and so on. Level you can bracket in the mainly axilla, name the groups, okay, instead of level, okay. Burke's level is there, Burke's level, but usually we use it as name. Next slide. So, cystial triangle lymph node, supracortical, opposite breast, opposite axilla, system. So, it should be the order, there is a confusion, there is somewhere there is a you are horizontally put, so that should not be there. Abdomen, characterize of spine, I said tenderness, whereas the spine movements. Again, Sadhan has mentioned that rotation movement is important. How to check also we had a discussion. Hypotomical ascites, especially for mainly for efficient nervous system. In sitting position, you have to check efficient. That's also important. So this slide is important for systemic metastatic lymph node workup. Okay. Next slide. So diagnosis how to put T3 and 1 back, go back. T3 and 1 M0. Then you go MX, remember. In the breast, there is no MX. Don't ever write. So how will manage? Evaluation triple assessment. First thing, how will manage triple assessment? Then group cut or core needle biopsy. Sir has already discussed why it is so. Again, I will repeat. Tie to grade, ERPR, R2 new K67. These are the four things you have to remember what to look for. And number 14, needle. And tissue will take, not cells. And metastatic workup, PET CT if it is T3 plus, otherwise chest CT and abdominal ultrasound and LFT, liver function test, methyl alkaline phosphatase. And treatment neoadjuvant therapy, MRN, breast cancer surgery if it's early breast cancer, breast cancer surgery with the axillary dissection. Radiotherapy you have to mention, we have not mentioned that, Sir has highlighted. Hormone therapy should be given last, that's important thing, not consecutively. Or consecutively, not concurrently. Hormone therapy will suppress the efficacy of the others if you do concurrently. Hormone therapy should be given at the end, not together. We can give chemotherapy and radiotherapy together, but not hormone therapy. That point you have to remember. Hormone therapy should be given consecutively, not concurrently. Chemotherapy and radiotherapy can be given concurrently. That point you have to remember. Mainly remember triple assessment and its features. Already Sir has discussed very clearly. Next slide. So this will be different. You can do the go back, nipple retraction, fungation, recurrent opposite side of breast, no carcinoma breast, operative carcinoma breast, previous history of carcinoma breast, it still be a pre-specific factor from the opposite side. 2% to 5% of the patient opposite breast carcinoma breast can occur in all the time, maybe 5 to 10 years. That's what exactly happened here. So lymphedema you have to look for. Nipple retraction, clearly carcinoma breast causing nipple retraction here. And fungation, you can see entire investigation node. Next slide. So how to examine breast, this one is highlighted in the fingers and palm. See the different methods of palpation of the breast. You can see the cystosarcoma highlighted here last slide. Last photo actually. Next slide. Again, skin involvement. See the patient disease actually. A skin involvement. Different details of patient disease you should know. And also lymph node involvement. So that almost inflammatory carcinoma or entire breast tissue node. See that opposite side mastectomy done on new, at the opposite side, opposite type breast type, this is started. You can see the skin involvement here. Nodules are there, redness is there. This is the typical patient disease where undergariola malignancy occurs. See that? Eczema is the differential diagnosis. Very typical patient disease, last photo. Next slide. So again, skin involvement, carcinoma breast. See that? Looks like malignancy is actually an inflammatory condition with ulceration, especially in diabetes it can occur. Again, carcinoma breast, again this one, again male carcinoma breast, lymph node involvement. Understood? Male carcinoma breast is more aggressive than the female because small breast spread is faster, but treatment is same like, staging and treatment is same like female breast, okay? Next slide. Next. So gynecomastia is everything you have to remember. Okay, again, carcinoma male breast, you can say suprarectal lymph node is not, axillary lymph node is not, fungation is there. See that? It's clearly suprarectal lymph node is this patient. You can see the beard here, so most with the male breast carcinoma. Maybe treatment is same, okay? Almost similar. Next slide. So mammography, ultrasound, see that ultrasound exactly looks like. Initially, always ultrasound important. MRI in certain patients, especially in the pregnancy, recurrent disease, those who have implants, you do MRI to assess it properly. So you can see the malignancy here in the mammography page. Mammography. See ultrasound exactly it looks like. See that very clearly. Cystic and this one. Next slide. So this is again axillary lymph node palpation important. And this is the mastectomy procedure. See that MRM axillary lymph node is there. Asynclosed type is the common leaf disorder. Okay, MRM currently is the mainly asynclosed type. Okay. So the entire breast is involved here. Maybe cystosarcoma filer, this one. Next slide. So MRM detail you have to know axillary lymph node level 2 you remove, not level 3 in this one. Level 3 is not removed. So axillary is the line. So below the level axillary you have to remove everything, level 1 and 2, not level 3. Never remove the level 3 in MRM. That's the point which you have to remember. Okay. So this is the MRM actual procedure. See that? Okay, next slide. So remember proper history, family history is very crucial. Already we have discussed that. Examine both the jugular neck. Find important lungs, abdomen, metastatic clinical assessment. So triple assessment, we already discussed. Logical, clinical, that is history and examination. Then FMEC lymph node, true cut biopsy, then ultrasound, of course, clinical ultrasound, true cut biopsy, or clinical imaging biopsy. This is the clinical assessment, clinical imaging biopsy, okay? PET CT, T3 on PET CT is important, otherwise in early stage, ECG test and ultrasound abdomen, serum alkaline phosphatase is also equally important. Mammography is definitely relevant in many patients. Then you have to remember, inspect axilla, check mobility, fixity, you have got a confusion there. Three muscles are important, petrous medial, lacuna dorsal, serratus anterior, pituitary chest wall moving is important, no pectoralis involved, in the chest wall. Serratus anterior and petrous muscle are ribs, that is the meaning of chest wall. So surgery, chemotherapy, radiotherapy, hormone therapy, because KA67 airport star has already told proliferative index it is, ER, PR, RQ, KA67 is a proliferative index, this is important currently now. Again, I will try to grading ER, PR, RQ, KA67. These are the things you have to check always to plan the treatment and decide the outcome. And how much chemotherapy, how much cycles, what radiotherapy, everything based on these things you will decide. Okay? Breast cancer surgery indications you have to remember. Early breast cancer, less than 4 centimeters, and all those things. You can read my book, it is there. But these are things you have to remember always. Next slide. Next slide. So that is about briefly. You have to read my website is there. All of you join, subscribe to see. You can daily MCQs are there. Please answer the MCQs, and many around 450 lectures are there. Go through the lectures whenever time permit. Instruments, suturing technique, everything is there in my website. My book, new edition has come, 8th edition with a complimentary MCQ book. My operative surgery. Clinical book, 4th edition is there with everything, all the examination is there in each chapter with a QR code. Okay, and you can always subscribe my website you and read and go through this one for all those relevant things whenever you want. So, sir, I thank you very much, Manoharan sir, Agartala, thank you, and Sardan, thank you, Anup sir.
Thank you, sir. Thank you, sir.
Thank you, Tarlan. Thank you very much for joining from UK. Hope tomorrow your Vipul surgery checks out.
Thank you, sir.
Send to me robotic.
Okay.
For Vipul's just see the photos.
Yes, sir.
Thank you, Bipasha Deb, you and Sourav. You have presented very well. Don't be worried for discussion. It's a discussion for learning, not to demoralize these people. You have done very well.
Thank you.
Sir, thank you very much. Executed very well. And thank you, my team, Subisha and team, my Whitelift team actually. They have done everything. Backup is there. Sardan, thank you for joining, and thank you everybody. Anup sir, we had some technical problem in joining. I thank you for of course allowing their student to present with this platform. I hope students have enjoyed. Everybody can put into the queries in the.
Sourav and Bipasha, both of you did very well, na? So congrats. Be bold and talk little more confidently. Otherwise, you are.
Thank you, sir.
I presented well, of course, a big topic. Every is a long case exam.
Nice, nice.
So, if you order the cases, they have done very well actually. So some discussions, so there will be problem. Don't worry. Otherwise, they were well done. Okay. So we'll wind up. I think. Thank you, sir, for joining me.
Yes, sir. Thank you.